Mr. Smith. Are you in any pain today? Let's do this. On a 0 to 10 scale, I want you to tell me where your pain is at. 0 meaning no pain at all, and then 10 being the most pain you've ever experienced in your life.
This is a numeric rating scale for pain intensity. These scales have been the standard in medicine for measuring pain for decades. This tool was developed to help medical providers better understand a patient's pain intensity level and the changes that occur after treatments, like medications. However, experts have started to understand that getting to 0 is frequently not the most important objective, that addressing physical function and emotional well-being is often as essential to getting patients back to active and productive lives. Many clinicians began to consider that there might be a need for an improved tool to guide the conversation and treatment decisions about pain. These observations resulted in the development of the Defense and Veterans Pain Rating Scale, or DVPRS. At its foundation, the DVPRS begins with the familiar 0 to 10 method of reporting pain. The DVPRS also incorporates other visual cues, including graduated intensity bars, the green, yellow, red color continuum, and a facial pain scale for those who might have difficulty communicating. Additionally, the use of mild, moderate, and severe pain levels correspond to the pain intensity colors and bars. When using the DVPRS, the conversation still begins with you communicating your pain level using the visual cues on the 0 to 10 scale. But what's important about the DVPRS is that the conversation doesn't stop there. The DVPRS continues the assessment beyond pain intensity. An important evolution in the DVPRS is the addition of functional language associated with the 0 to 10 numbers, anchoring your pain experience in terms of how it impacts your level of function, what your providers call functional disturbance. With the inclusion of these anchors, two things are accomplished. First, as you become familiar with these functional anchors, the pain question will have greater meaning to both you and your providers, and the recorded pain values will have greater clinical value. Also, by recalibrating the pain discussion from intensity alone to one that emphasizes your function, you and your clinicians can now discuss pain and measure success of pain management in the larger context of what treatments actually improve your function, thus reducing the likelihood of medication-centric pain management aimed solely at getting the pain to 0. Additionally, because pain often transcends a simple measurement of intensity and affects many areas of your life, the DVPRS also includes some additional questions aimed at providing insight on the impact of pain in 4 key areas: activity, sleep, mood, and stress. These questions take only a few extra seconds to answer, but they provide important indicators of the success or failure of pain management therapies far beyond what is obvious when only focusing on pain intensity. It is not uncommon for many people to remain relatively static with their pain intensity scores for a period of time. However, changes can be observed in the other measures that indicate improvements in a person's quality of life. Assessing these other dimensions of pain is critical to your provider's understanding of how pain might be affecting your overall well-being and can alert to potential physical and psychosocial issues related to your pain. The DVPRS can be used whenever pain is discussed or assessed. It provides valuable information and insight to both you and your healthcare team as you work together to develop appropriate treatment plans for managing your pain.
There's one thing I hate most about doctor's appointments, and that is the pain scale.
Absolutely. Yeah.
Save me from this. Tell me.
Well, first and foremost, they ask the injured worker, what's your pain? Between 0 being no pain and 10 being the worst pain. Well, who knows what that means? They never go on and describe it further. And then they use it against the injured worker when they say, oh, I have 11 pain.
Well, or even 10 or 9.
Right.
If patient complains of 9 pain of 9 out of 10, but sits comfortably throughout the exam.
Right, it's ridiculous. So when I sit clients down, I advise them, what the pain scale actually means. 10 being you are actually having thoughts of hurting yourself.
Well, I go further. I go at 10. You are capable of thought.
Right.
You are capable of speaking,
Absolutely.
eating, moving. If the building were on fire, you wouldn't even know it was on fire. You just die in the flames.
9 pain, can't get out of bed. A loved one needs to take you to the emergency room.
Right. And you're certainly not eating or going anywhere with a 9.
Right.
You know.
Right. So automatically, if you say 9 or 10, and you're in front of them, they completely discount your pain complaints,
Right.
Because they feel like you're exaggerating. And remember, these are the insurance carriers, doctors looking for any reason to give the insurance carrier a way to get out of the claim,
or a way to minimize treatment.
Right.
Because how often have we seen, their pain and complaints are in excess of the objective findings, so I don't recommend surgery for this person because it's going to be that way. Yeah, no, I agree.
And once again, they're incentivized to minimize the treatment for the injured worker,
Exactly.
because that saves the insurance company money.
I mean, this discussion just explains to me, if it isn't clear why you need somebody there guiding you through this system to help you avoid problems, I don't know what else is, because people, when they go to the doctor, they think that they're going to a friend, somebody who's there to help them, and there are all these pitfalls. I think you just have to have a lawyer to avoid this stuff.
I agree.
Call us for a free consultation.
When you become a PT or a PTA, you learn something called the pain scale. This is what we use to ask patients what their pain level is. So typically what we say is 0 to 10, 0 being no pain at all, and 10 being the worst possible pain. We have to take you to the ER right now. What is your pain level at? And if you've ever been to like a doctor's office, you can see their chart that's like the person smiling is a 0, and then like all the way down to a 10 is like the person crying. That's the same thing. But here's what I think. I think we should change how we explain the pain scale to patients. There's times when I have patients who come into physical therapy and they look like mangled, they have like a broken arm or something, and they say, Tony, I have 0 out of 10 pain, and I'm just like, whoa, that's kind of crazy. You got a good pain tolerance there. But then on the flip side of that, I have patients who come in sometimes like smiling, skipping, laughing, and they come and sit down and they tell me, Tony, my pain is a 10 out of 10. So I'm like, well, pack your bags then, we gotta go to the ER. You know, like sometimes I just don't feel like they fully understand what the pain scale is, even though I explain it to them. There's this one time I had a patient who told me their pain was an 11 out of 10. Like on a scale that goes up to 10, their pain was an 11. And they were sitting there talking just fine, they look normal. And I'm like, what goes past a 10, like 11 out of 10? 10 is the worst pain you've ever felt. Like, are you dying at this point? Like, what is an 11 out of 10? I don't know. This person's in trouble. So this is how I think the pain scale should be explained. 0 out of 10. This is where you have no pain at all. You should be feeling 100%. Honestly, I'm thinking like, what are you doing in therapy right now? You're feeling great. So 0 out of 10 would be no pain. 1 out of 10 pain. I would describe this as like having an itch. Like if you've ever had poison ivy and it like itches a little bit, like it's kind of like, ugh, goodness, it scratches. Like if you have a 1 out of 10 pain, that's what you should be feeling. 2 out of 10 pain, I think that you might need like a Band-Aid. If I was gonna tell you how bad you're hurting, it's like a Band-Aid level. So like my nieces or nephews, when they barely like stub their toe or have a bump or something, they instantly want a Band-Aid. That's what a 2 out of 10 is. 3 out of 10 pain is like a nagging spouse or something, like, ugh, quit it, you know, like quit bothering me, pain. It's more of an annoying nuisance. Now 4 out of 10, things are starting to heat up a little bit. I think it's kind of getting to that moderate pain level, but you're still able to work. Like it's concerning, but you're still loading the dishwasher and brushing your teeth and you're working your 9 to 5, you know, so that's what a 4 out of 10 is. I would describe 5 out of 10 pain being like a bee sting. Like, ugh, no one loves a bee sting. Oh, It's the worst sensation ever. Like, just stings for a while and like, ugh. But imagine that never going away. So it would be annoying. It would kind of be irritating, like a bee sting. Okay, 6 out of 10 pain. We are getting kind of crazy now. This is what I would picture to be like a swarm of bees. You know, like if you were reaching in the fridge and you thought you were grabbing the Kool-Aid, but instead you grabbed a bee's nest and the bees started getting you, like that is a 6 out of 10 pain. When a swarm of bees are getting you, yeah, you're hurting. 7 out of 10 pain would be like uncontrollable crying. Like you are weeping because you are in agony. You are hurting so bad that the tears just keep coming. You know, that's the kind of pain you'd be at. 8 out of 10 pain is you literally cannot move because you are hurting so bad. You are frozen in space because it hurts so bad to move. Like, I've fallen and I can't get up kind of pain. Life Alert sponsored this video. They didn't. But if they did, it would be cool. But, yep. 9 out of 10 pain is you being mauled by a bear, like a literal bear attack where it is eating you limb from limb. That's a 9 out of 10 pain. If you are not being mauled by a bear, Karen, then you do not have 9 out of 10 pain, because 9 out of 10 pain is you are slowly being eaten. So that, yes, you're fine. Walk it off. 10 out of 10 pain is the worst pain you could possibly have, and I would rate this as like you're unconscious. You are basically dead. You have maybe on the brink of dead. You are decomposing dead. You're being eaten alive. The maggots are to you at this point. That's how 10 out of 10 is. And if you're at 10 out of 10, we gotta get you to the ER. So don't say it unless you mean it, because pack your bags, we're going right now, I'll take you there. So the next time you explain the pain scale to somebody, I hope you use it this way and see how they respond, because maybe they'll give you a different answer. Anyways, this was just a silly video. This was just for no reason at all. Just me talking. Hope it was helpful. See ya. Peace.
Sure. So, you talk about some assessment tools, and historically, I mean, we've even talked before that the numeric rating scale might not be so helpful for your patients with chronic pain. But I like the numeric rating scale when I ask patients, okay, tell me about your all day long pain and tell me about your breakthrough pain. One of the pharma companies dropped off a quick little index card with the 2 scales on it, one for the all day long pain and one for the around the clock, for the breakthrough pain. And it really has helped me over the years to assess patients using the numeric scale, comparing what is their all day long pain to what is their breakthrough pain.
But Jeff, you kind of want to be very careful in your analysis to know, well, is this breakthrough pain occurring at the end of a person's dose when they're about to take their next drug? Is this pain spiking idiosyncratically, idiopathically, for no apparent reason, which is of course less predictable? Or is that pain spiking because they're now more active than ever before and being positive, and they're gardening, and in order to accomplish that, they know they're going to get a breakthrough episode above and beyond their baseline pain, which is controlled if they're gardening, going to physical therapy, maybe exercising. So it's important to use those tools in the context of how is that person's function being impacted.
That's a great point, Charles. It just teaches us that there are different kinds of breakthrough pain. Right. And Charles mentions the end of dose failure. They're long-acting analgesic wearing off, spontaneous types of pain, and then mechanistically exacerbations of pain with intentions or with activities.
And one more thing I just want to mention is, for these patients, there's such a different, niche group because they've been exposed to, significant radiation. They have neuropathic issues from chemotherapy. It's just very important to understand that there's many different types of presentations that could mimic, chronic acute breakthrough. So it's a different type of treatment approach to cancer patients versus your non-cancer patient population.
So let's talk about those presentations.
Pain assessment in critically ill patients is a challenging task. During intensive care unit admission, patients can experience pain during various stages of critical illness and different procedures. Self-reporting of pain is possible in non-ventilated patients, but it is difficult in ventilated patients. various scales are available for pain assessment. In patients where self-reporting of pain is possible, a visual analog scale or numeric rating scale and a behavioral pain scale for non-intubated patients can be used. For patients who are unable to self-report, a behavioral pain scale and a critical care pain observation tool or CPOT should be used. Of note, vital signs should not be used as surrogates for pain assessment. The most common self-report method for pain assessments are numeric rating scales, typically from 0 to 10, with 0 representing no pain and 10 representing severe pain. A preferred scale for ICU patients who may not be able to verbalize, but are interactive, is the Visual Numeric Pain Rating Scale, in which the scale is shown in large font, with no pain next to the number 0 on the left side of the scale and extreme pain next to the number 10 on the right side of the scale. The CPOT is used in patients who are intubated and cannot report pain. It includes assessment of facial expression, body movements, compliance with the ventilator, which is replaced with vocalization for extubated patients, and muscle tension. This scoring system is on a scale from 0 to 8, with scores greater than 2 signifying an unacceptable level of pain that requires treatment. In the next slides we'll detail on the description of each indicator. The facial expression is one of the best behavioral indicators for pain assessment. A score of 0 is given when there is no muscle tension observable in the patient's face. A score of 1 consists of a tense face, which is usually exhibited as frowning or brow lowering. A score of 2 refers to grimacing, which is a contraction of the full face including eyes tightly closed and contraction of the cheek muscles. On occasion, the patient may open his or her mouth, or if intubated, may bite the endotracheal tube. Any other change in facial expression should be described in the chart, and given a score of 1 if different from a relaxed or grimacing face. Body movement is the second indicator in CPOT. A score of 0 is given when a patient is not moving at all or remains in a normal position as per the nurse's clinical judgment. A score of 1 refers to protective movements, meaning that the patient performs slow and cautious movements, tries to reach or touch the pain site. A score of 2 is given when the patient is restless or agitated. In this case, the patient exhibits repetitive movements, tries to pull on tubes, tries to sit up in bed, or is not collaborative. Of note, body movements are the less specific behaviors in relation with pain, but are still important in the whole evaluation of the patient's pain. Compliance with the ventilator is used when the patient is mechanically ventilated. If the patient is not intubated, then a vocalization indicator is used, as it will be shown in the next slide. A score of 0 refers to easy ventilation. The patient is not coughing nor activating the alarms. A score of 1 means that the patient may be coughing or activating the alarms, but this stops spontaneously without the nurse having to intervene. A score of 2 is given when the patient is fighting the ventilator. In this case, the patient may be coughing and activating the alarms, and an asynchrony may be observed. As indicated in the previous slide, vocalization is used in non-intubated patients who are able to vocalize. A score of 0 refers to the absence of sound or to the patient talking in a normal tone. A score of 1 is given when the patient is sighing or moaning, and a score of 2 when the patient is crying out or sobbing. Lastly, muscle tension is evaluated by performing a passive flexion and extension of the patient's arm when the patient is at rest. During turning, the nurse can easily feel the patient's resistance when she is participating in the procedure. A score of 0 is given when no resistance is felt during the passive movements or the turning procedure. A score of 1 refers to resistance during movements or turning. In other words, the patient is tense or rigid. A score of 2 consists of strong resistance. In such cases, the nurse may be unable to complete passive movements or the patient will resist against the movement during turning. The patient may also clench his or her fists. In summary, clinicians should assess critically ill patients for their level of pain regularly, using self-report if possible. Pain should be reassessed every 2 to 3 hours and more frequently before painful procedures or mobilization. Numeric rating scale should be used in patients who can communicate. If the patient cannot communicate, then one should use validated behavioral pain scales such as CPOT. Pain should be addressed with non-pharmacological methods or with medications if NRS is more than 3, or if CPOT more than 2. In the next step, we will discuss management of pain in the ICU. Thank you.
Welcome to this video on assessment tools for pain. Assessment tools for pain are instruments that help you measure a patient's degree of pain in addition to assessing patients' conditions and needs. Some assessment tools for pain are observational, based on patients' responses that can be seen, such as their expressions and body positions. Other tools are subjective and based on the patient's own self-assessments of their pain, usually guided by some scale. In this video, you will learn about some of the most common assessment tools for pain, including the Wong-Baker Faces Pain Scale, the Numeric Pain Rating Scale, the Visual Analog Scale, categorical scales, the Brief Pain Inventory, the McGill Pain Questionnaire, and the Critical Care Pain Observation Tool, or CPOT. First, let's take a look at the Wong-Baker Faces Pain Scale. This scale was originally designed for children ages 3 and older and is most commonly used for preschoolers and young children who are not yet able to use numbers to rate their level of pain. Children choose a face that matches their level of pain. The Wong-Baker Faces Pain Scale can also be used with adults, especially those with language barriers or intellectual disabilities. Next, the Numeric Pain Rating Scale is the scale most commonly used for children 6 years and older, adolescents, and adults. Patients are instructed with a statement such as, on a scale of 0 to 10, with 0 being no pain and 10 being the worst pain you can imagine, how do you rate your pain? With the Numeric Pain Rating Scale, the score represents the degree of pain. 0 represents no pain, 1 to 3 represents mild pain, 4 to 6 represents moderate pain, and 7 to 10 represents severe pain. The Visual Analog Scale is similar to the Numeric Pain Rating Scale, but usually lacks the intervening numbers between 0 and 10. The Visual Analog Scale indicates the intensity of pain only. Patients are instructed, if the beginning of the line is no pain and the end of the line is the worst pain you can imagine, where on the line is your pain? Patients then place a mark or point to a spot on the line that represents their degree of pain. In addition to the other types of scale, categorical scales depend on words rather than numbers to indicate the intensity of pain. Categorical scales are appropriate for children 7 and older with adequate reading and comprehension skills, and adults with adequate mental abilities and language skills. One example of a categorical scale is the Verbal Pain Intensity Scale, which rates the intensity of pain as no pain, mild pain, moderate pain, severe pain, very severe pain, and worst possible pain. Another pain assessment tool that is more comprehensive is the Brief Pain Inventory, or BPI. The Brief Pain Inventory is intended primarily for adults, but may be used with some adolescents, such as those with rheumatoid arthritis. The Brief Pain Inventory is used to assess clinical pain, such as cancer pain or other chronic pain. The Brief Pain Inventory includes body illustrations so that the patient can indicate locations of pain. The Brief Pain Inventory also includes a number of numeric scales, 1 to 10, that assess different aspects of pain. These include worst pain in previous 24 hours, least pain in previous 24 hours, average pain, current pain, pain relief in percentage from medications in the previous 24 hours, and pain interference in the previous 24 hours with general activity, mood, walking ability, normal work ability, outside and housework, relations with other people, sleep, and enjoyment of life. Next, the McGill Pain Questionnaire is a self-reporting tool intended for adult patients with significant pain from cancer or other types of chronic pain. This tool helps to assess changes over time and response to interventions. Both a short version and a long version are available. The long version contains 20 different dimensions of pain, such as temporal, spatial, and constrictive pressure. Each dimension has 1 to 5 descriptors that are assigned points. The patient chooses the most appropriate descriptor for each dimension. For example, dimension 5, constrictive pressure, pinching 1 point, pressing 2 points, gnawing 3 points, cramping 4 points, and crushing 5 points. In addition, the McGill Pain Questionnaire asks the patient to choose descriptors about how pain changes over time, patterns of pain, items that increase or decrease pain, and strength of pain, current pain, worst pain, least pain. The higher the total score, the greater the pain. Last, the Critical Care Pain Observation Tool, CPOT, is an observational tool for a specific population of adults that are in critical care and who are unable to self-report, intubated, and or sedated. The Critical Care Pain Observation Tool assesses pain on a 0 to 2 scale by observation of facial expression, body movements, muscle tension, compliance with ventilator if intubated, and vocalization if extubated. A score of equal to or greater than 2 indicates pain. Choosing an appropriate pain assessment tool and carrying out routine assessment is critical to pain management, but it's important to remember that the pain assessment tool should be a first step in pain assessment, not the only step. Many of these pain assessment tools, such as the numeric pain rating scale, consider only the intensity of pain. However, pain is multidimensional, and pain assessment should be likewise multidimensional, considering such factors as duration, location, emotional response, physical response, aggravating factors, and mitigating factors. Thanks for watching, and happy studying.
Welcome to the Karmanos Cancer Center. We at Karmanos consider pain management a priority. To help us to understand your pain experience and to help us to develop an effective treatment plan, we need you to partner with us. To facilitate this partnership, we have developed a 3-part education program to help you to understand the process of a pain assessment and the pain assessment tools that we use to help us to best understand your pain experience. We ask that you take the time to review each of the 3 sections. You may view them all together or at different times, and you may repeat these sections as many times as you choose. After viewing these presentations, if you need further help with understanding any of the material, please request clarification from your nurse or ask to speak with the pain management coordinator. The goal of this education series is to help us to understand each other, to make certain that we are all speaking the same language. Our goal is to effectively manage your pain, and to best accomplish this, we need you to be an active participant in your pain management care and treatment plan. We will work together toward an acceptable and realistic pain level for you. We will look at your activities, your appetite, your sleep habits, and your mood, as these all impact on your pain experience. We will need you to work together with us to make this happen. Your pain experience is unique to you. We can't actually feel your pain, but there are tools that we use to help you, to help us to best understand how you are feeling. First, let us define pain. The pain experience is different for everyone. Pain is often described as an unpleasant feeling and can be caused by any number of reasons, including surgery, disease, or injury. Pain is made worse with stress and anxiety. Your pain is whatever you say it is. In this first presentation, we want to explain to you one of the tools we use to help us to understand how you rate your pain and how you rate the treatment that you receive. The information obtained by using this tool is just one factor used to help us understand your pain experience. We can easily evaluate for signs of a fever with the use of a thermometer. We can take a pulse and use a blood pressure cuff to monitor heart function. But we do not have an instrument to measure pain. What we do have is a tool in the form of a numeric 0 to 10 scale. This enables us to rate your pain level and to evaluate your response to a treatment or medication. Most of you may already be familiar with being asked to rate your pain on a 0 to 10 scale, but you may not totally understand how and why this tool is used. When you are in the hospital, you will be asked to rate your pain before a medication or treatment is given, and again 1 hour after you receive that medication or treatment. When you are being seen in the outpatient clinic, you will be asked to rate your pain level at every visit. At Carmanis, we use the numeric pain scale with faces as the tool to rate your pain level. This is a standard and tested tool. This tool consists of numbers from 0 to 10 and faces with expressions to accompany these numbers. At one end of the scale is 0 with a happy face, representing no pain. At the other end is a 10 with a very sad and tearful face, representing the worst pain. As the numbers on this scale increase or get higher, the facial expressions also change, reflecting mild pain, discomfort, distress, and horrible pain. Your pain rating is whatever you say it is. The expectation is that whatever your starting number is, that number will go down or become less after a pain treatment or medication is provided. A 0 pain rating might not be realistic for everyone. Our goal here at Carmanis is to get and keep your best possible pain rating based on your individual condition. We know that some situations a patient can only report a 4 out of 10. You and your provider can work together to determine a realistic pain rating goal for you. An example for use of this rating tool would be a patient is in the hospital and rating his pain level a 7. He then receives a pain medication. The nurse returns an hour later and the patient reports to the nurse that the pain level is now 3. This report by the patient indicates that the pain medication is doing what it's supposed to do. This medication will now be provided to the patient to maintain this acceptable level of comfort. If the number were to remain a 7, the nurse would then need to contact the provider to determine a possible change in the treatment plan. Another example, a patient in the outpatient clinic reports a pain level of 7 out of 10 at her first visit. The provider then orders a treatment or medication at this visit for the patient to take it home. When the patient returns for the next follow-up visit, she reports significant improvement and rates her pain level as a 3 out of 10. Again, this communicates to the provider that the prescribed treatment or medication is working and providing an acceptable and realistic level of pain relief. What is important to understand about this tool is that it is just one of the measurements used to communicate your pain experience. The number that you choose to start with is your number. It is whatever you say that it is. The numeric rating scale helps us to communicate more effectively with each other by providing a common language. This numeric scale, in addition to an evaluation of your activities, your appetite, your sleep, and your mood, is an effective and standard way for you to communicate your pain experience. This communication has been found to be the most objective way for your provider to best understand what you are experiencing. Better communication between you and your provider will then better enable your provider to determine the most effective management for your pain experience. Your participation is critical. This ends section 1. Let's just review a few key points from this section. We want you to know that we at Carmanis are very interested in managing your pain. That we need your help in understanding your pain because we don't have an instrument that can tell us how you are feeling. We need you to understand what we are asking when we ask you to rate your pain on the 0 to 10 numeric scale. And we want you to know that using a 0 to 10 scale is a communication tool that allows you to rate your pain before and after a treatment, helping us to determine if the treatment is helping to reduce your pain. Your goal from treatment will be what you and your provider determine is realistic for you. You may repeat Section 1 for a review or go on to Section 2. If you need help to better understand this section, you may ask your nurse or ask to meet with the pain management coordinator. Also, the numeric pain scale is available in different languages. Just ask your nurse if you would like to see one in another language.
Hi, my name is Dr. John Chim, and today I want to talk about how doctors feel your pain. The truth is, we don't, so we need your help. When you come to the office, you have to prepare to be asked questions about your pain. For instance, when did the pain start? How severe is the pain? Does the pain travel from one part of the body to the other? In other words, when you feel pain shooting down your arm or shooting down your legs, do you think the shooting pain is caused by the pain in the upper part of your neck or back? We also need to talk about something called the pain scale. We call it the visual analog scale. It's a scale between 0 and 10. 0 means no pain, and 10 is the worst pain you've ever experienced. And if you haven't experienced bad pain, think about somebody operating on you without anesthesia. In between is a 5 out of 10 scale, which means you experience the pain when you're doing activities that you need to do. Thanks for taking the time to watch this video. When you come to the office, prepare for those questions that we discussed. Thanks.
Is there any way you could measure pain, or any scales you can use? Because if someone's admitted, I know in New York State, they want you to say the pain in terms of some kind of value. Is there any kind of scale you would use?
Right, so the most common scale is called the visual analog scale, and it's rated on a scale of 0 to 10, 0 being no pain, and 10 being the worst pain that you can imagine. And anywhere within that spectrum, we can place a number and get a sense of what degree of pain an individual is experiencing.
So you could use that kind of a scale to say whatever you're doing is improving and not improving. Is that correct?
Exactly.
If someone asked you to describe pain with just one word, what word would you use? Pain is pain, right? Well, the truth is, pain is different for everyone. The way I experience and describe pain will most likely be completely different than the way you might experience and describe pain. Pain is one of the most subjective of life's experiences. We all experience it, but the way we experience it differs from one person to the next. If our pain becomes severe enough and it becomes time to consult a physician, being able to accurately tell your doctor where it hurts and how long it's been hurting is a vital piece of information needed to diagnose your condition and determine the proper course of treatment. To aid you in describing the pain you are experiencing, physicians will typically use a pain scale to help you articulate your pain. There are several types of pain scales a physician might use to help you understand your pain. The most common pain scale employed by physicians today is a numeric pain scale. A numeric pain scale helps you quantify your pain using numbers, sometimes in combination with words. Your physician will ask you to rate your pain on a scale from 0 to 10. 0 would represent no pain, and 10 would represent the worst pain imaginable. Another type of pain scale is the verbal pain scale. With a verbal scale, you can describe the degree of your discomfort by choosing one of the verbal indicators that most corresponds to the intensity of pain you are feeling. Even though there is no numerical rating, doctors can look for a change in the intensity of pain words. A less commonly used pain scale, but yet still an accurate tool for physicians, would be the visual pain scale. It offers a visual description for those who don't have the verbal skills to explain how their symptoms make them feel. Visual pain scales have pictures of human anatomy to help you explain where your pain is located. The most common visual scale used today is the Wong-Baker Faces Pain Rating Scale. This type of pain scale features facial expressions to help you show your doctor how the pain makes you feel. This scale is particularly useful for children who sometimes don't have the vocabulary to explain how they feel. To be most accurate, all pain scales are best used as the pain is occurring. When a physician asks you to rate your pain, honesty is the best policy. Don't exaggerate your pain. Your physician needs an honest assessment of your pain in order to devise an optimal course of treatment. The more accurately you are able to describe your pain experience, the better your physician can help you control your pain.